Good morning. On behalf of my colleagues, I'd like to welcome you to our 4th annual Valve Awareness Day. My name is David Skolnick. I'm one of the 65 cardiologists at St. Luke's Mid-America Heart Institute and the medical director for our Valve Center of Excellence. In just the past several years, the clinical landscape for the management of heart valve disease has changed and continues to change at an extraordinary pace. Our team at St. Luke's has been an integral part of this exciting journey. To fill out that story a bit, I'd like to highlight 3 points. The first, game-changing technology like TAVR and MitraClip has brought new treatment options for patient care. For those of you who are not familiar with the terms TAVR and MitraClip, they are catheter-based options to replace or repair heart valves without the need to open the chest. We have offered TAVR for over a decade, and we started our transcatheter mitral valve program in 2015. Second, we have gained a much more nuanced understanding about heart valve disease as our team has further subspecialized in this rapidly evolving field and participated in numerous clinical trials and clinical research projects. And 3, the number of people in our community with valve disease has led some experts to describe it as the next epidemic in cardiology. With that background, let's get started. The first slide outlines today's program. Following our 5 presentations, we will offer you a virtual cath lab tour where we perform our transcatheter aortic and mitral valve procedures. Throughout the presentations as well as the tour, you are welcome to ask questions in the chat box, which you will find in the bottom right-hand side of the screen. My presentation is to give you an overview and an introduction to valvular heart disease at St. Luke's Mid-America Heart Institute. This next slide shows you the essence of how we practice cardiology at St. Luke's Hospital. We value clinical excellence, education, and research. And let me just give you an example of how this translates into our valve program. We started our TAVR program well over a decade ago. That allowed us to gain more experience. We became early adopters of new technology that allowed us to become participants in new clinical trials. We're now in the mitral space and the tricuspid space, which you'll hear about later this morning. In this field of education, we have an academic training program to teach the next generation of cardiologists. Along the way, we become better educators. We learn more ourselves, and then we get to recruit the best of our own trainees. Also, our mission is to educate the patient and the community, which is what today's session is all about. We are proud that we were Kansas City's first recipient of the Valve Award from the Joint Commission, which in the end improves systems of care and our team-based care to offer you better outcomes for patients who have heart valve disease. This publication last year highlights many of the unique cardiovascular programs that you will find at St. Luke's Hospital. We are very proud that U.S. News and World Report honored us as the 22nd best cardiovascular program in the country. There are about 1,200 heart programs in this country. This outlines the myriad of programs that you'll find at St. Luke's Hospital. On the left-hand side are many of the unique cardiovascular programs that we have and offer on a daily basis. We have a huge investment in the idea of prevention. We are heavily invested in research and in education. Today, we're going to focus on valvular heart disease. So let's get started. This is a simple chest x-ray we've had for 100 years. You don't see the valves. In a more modern understanding of valvular heart disease, in this illustration, you can see the 4 valves that open and close as the heart pumps. This diagram is here to highlight the 2 valves that we're going to talk about primarily, aortic valve disease and mitral valve disease. These are the most common issues that we find in patients who have heart valve disease. We will also touch a little bit about the new and upcoming treatment options for tricuspid valve disease. If you see here the dotted line, we're going to now slice the heart along this plane. And this illustration shows the left atrium up top, which we removed here. You see the mitral valve outlined here now in red, supported by a myriad of ropes and strings, which we'll explain in a moment. The left ventricle then pumps and sends the blood out the aortic valve to the aorta. On echo, this is a still frame showing the left atrium, the open mitral valve, the left ventricle, and a closed aortic valve. And when all this thing moves with the color, you will see that blood leaves the left atrium, goes into the left ventricle, this valve closes, the ventricle pumps and squeezes, and blood, now colored in red, will leave the heart out the aortic valve. Of the two issues that we're going to talk about today, one is the aortic stenosis and the other is mitral regurgitation. So what you need to know is that a normal aortic valve, when it opens completely, it looks like this. And you should think of the analogy as a garden hose with no nozzle and the water just easily flowing out of the hose. That's normal flow through a heart. No obstruction, and the blood easily leaves the aortic valve. When you have a heavily calcified aortic valve, you can see that the valve barely opens, and the opening is severely reduced, and we call this aortic stenosis. The analogy would be as if you put your thumb at the end of the garden hose and created a huge spray because of the narrowing or the obstruction that your thumb caused. This is what it looks like on echo. This is the heavily calcified valve, and this is the small opening. And if you want kind of an understanding in a picture form, this is what your heart does when it really struggles with a very small opening. The other issue that we see commonly in the adult world is mitral regurgitation. This is an example of a leaky mitral valve prolapse. This is the anterior leaflet, or one of the two leaflets, that is held and tethered, if you will, by a series of ropes and strings outlined by the blue arrow and tethered to the heart. And here you can see the cord of the rope is cut or torn, and this leaflet flops backwards into the left atrium. In this analogy, I want you to think of a parachute, which each leaflet, the posterior leaflet or the anterior leaflet, is held by a series of ropes and strings. And you can imagine what happens if you would take a couple ropes and cut them with a scissors. This is what it looks under echo. This is the rope and string that should be tethered here, and this is the other one that is appropriately attached. And in this space, you will now see, when you turn on the color, a significant amount of mitral regurgitation or leaky valve where the blood is sliding through this hole and back into the left atrium, and it ultimately will back up into the lungs, and patients will present with shortness of breath. How common is heart valve disease? This graph illustrates the answer. When we reach our mid-60s, and certainly greater than 75, the incidence of aortic and mitral valve disease increases a lot. We speak a lot about aortic valve disease, and significant aortic valve disease is about 3.5% to 4% of our older patients over 75, and there's twice as much as mitral valve disease. This graph here shows you that in the next generation, the over 65 group will double in their population, and those over 85 will triple. You apply this math to this graph, and you can imagine that in the next several decades, the incidence of heart valve disease will continue to grow as our patients age. So how do we make the diagnosis of heart valve disease? Well, patients often come to us with the first three symptoms commonly: shortness of breath, fatigue, and swelling. Chest pain is not common, though occasionally they do present with chest pain. But you would also acknowledge that these are relatively vague symptoms and cover a lot of potential diagnoses. The next step is physical exam. We've had the stethoscope since the early 1800s. This is a Norman Rockwell picture showing that the start of our evaluation is with auscultation and listening to the heart. The kids who are graduating from medical school today will likely move to a much more sophisticated form of evaluating heart sounds and heart function with portable ultrasound. This is probably just around the corner. But today we use sophisticated echocardiography or ultrasound of the heart to look at how well the heart pumps and squeezes, and this is normal heart function. We turn on the color that I showed you, and this yellow band is a tremendous amount of mitral regurgitation or leaky mitral valve. We now have very sophisticated imaging with three-dimensional echo to look at how the valve opens and closes. And we have something called spectral Doppler and continuous wave Doppler to measure these gradients, kind of looking at the spray of the garden hose that I showed you. It seems that the management of heart valve disease is getting more complicated almost every day. Not that long ago, the American College of Cardiology published this graphic to show you all the nuances and variations of just severe aortic stenosis. It's even more challenging for the mitral space, with lots of pathways that ultimately end with the recommendation of being seen at a valve center. In the end, the American College of Cardiology recommends the following. The management of patients with complex, severe valve heart disease is best achieved by a heart valve team at a center of excellence. And here's the St. Luke's difference. We have a multidisciplinary valve team that I'll show you in just a moment. We are really driven by a focused quality outcome. We have a collaborative team, and at the end, the patient is the center of our attention. And this is how we approach patients with heart valve disease. It is a team. Diagnosis, as I told you, is based on echo frequently. We have cardiac surgeons and interventional cardiologists. We need a team of anesthesiologists. The referring physician and our heart failure colleagues are an integral part to the management of these patients. In younger patients, we have an adult congenital heart disease program in conjunction with Children's Mercy Hospital, and we have other complex, sophisticated imaging to help us elucidate etiologies, mechanisms, and severity of valve disease with CT and cardiac MRI. We are proud that several years ago, we received the Joint Commission certification on our cardiac valve repair and replacement program. Our mission is accuracy in diagnosis and excellence in outcome. And these are the issues that we embrace. We want to reduce the variation in care. We want to improve efficiency and enhance collaboration. We want to promote a culture of excellence and continue to be a center for clinical trials. In the end, our goal is to ensure that our community, you, our patients, have access to highly subspecialized care. I'd like to just give you an example of the speed of technology that we have witnessed in the management of valve disease in general. I'm going to take you back to the late 1700s. There was a French physician named Bottineau who is credited with publishing and describing the first young man who died of severe obstructive calcific aortic stenosis. It took almost 300 years to come up with a mechanical solution for a mechanical problem. Dr. Starr and his engineer friend, Dr. Edwards, came up with this initial surgical option of a ball and cage replacement to fix the mechanical obstruction. In the mid-70s, a French physician by the name of Alain Carpentier came up with a tissue valve in lieu of a mechanical valve to replace the aortic valve. It was unbelievable that not that long ago, Alain Carpentier, another French surgeon, came up with this idea to replace the valve with a catheter and a valve mounted on a metal frame. We are proud that we were the first in Kansas City and perhaps one of the first 15 or 20 in this country to participate in a landmark trial asking the question, can we serve our patients better with TAVR? That answer turned out to be yes. The FDA approved that first clinical trial in 2011 and shortly thereafter approved a myriad of other clinical trials for other patients who would benefit from TAVR. And in just 10 years, these are the 9 clinical trials that we participate to help advance the science of TAVR-based catheter intervention for patients who have severe aortic stenosis, and these studies continue at St. Luke's Hospital. I'd like to share with you the program that we've built together with our surgical colleagues and the rest of our valve team. The story, as you remember, starts in 2008 when we started our first clinical trial projects on a national trial. The program really started in 2012 with FDA approval, and over the years, our TAVR program has grown. This was our first TAVR clinic. The American College of Cardiology came out with new guidelines. We then embraced a 5-year strategic plan to improve and grow our valve program. We created a Valve Center of Excellence in 2016. We outgrew our initial TAVR clinic and we needed to expand and moved into the hospital to accommodate the patients who would benefit from this technology as our TAVR program continued to grow over the years. We then received the Joint Commission award that I mentioned earlier. Our mitral valve program, which started in 2005 for a catheter-based option, became large enough to now have its own freestanding clinic. Just 2 years ago, we started a transcatheter valve option for the tricuspid valve. These are our volumes from last year, and these are our volumes programmed to date. There are few centers in Kansas City that have this robust experience. For our current state at St. Luke's Hospital, for FDA-approved transcatheter options, this is one of the 2 valves available for TAVR, and this is our catheter-based option for mitral valve intervention. And these are the 4 clinical trials that we're working on to further advance our understanding and treatment of patients who have mitral valve disease and tricuspid valve disease, and you'll hear more about that in the next lecture. For patients who have heart valve disease and come to our program at St. Luke's, our first goal is to make an accurate diagnosis and to determine whether we can treat you medically and follow you over time, or whether your valve disease has advanced that we need an intervention. Some patients will need surgery, and my colleagues in a few lectures will explain to you the idea of a mechanical valve or a tissue valve as surgical options. Some patients may benefit very well from a repair of the mitral valve. And for those who need transcatheter-based options, We have a host of them, and my colleagues in just a few moments will walk you through those options. Thank you. Our next speaker is Dr. John Saxon. He's going to give us an update on transcatheter aortic valve replacement, which we call TAVR.
My name is John Saxon. I'm an interventional cardiologist here at St. Luke's Mid-America Heart Institute. I'm going to talk to you about aortic stenosis today, new therapies for an old problem. As you know from Dr. Skolnick's talk earlier, aortic stenosis is a narrowing of the main outflow valve of the heart, known as the aortic valve. You can see in the top there a healthy aortic valve. So it's made up of 3 pieces of tissue, typically, that open and close smoothly. And those thin pieces of tissue open and close every single time your heart beats your whole life. On the bottom row, we see findings of aortic valve stenosis. So over time, the aortic valve itself can become degenerated and scarred with mineral deposits and buildup of calcium. That stiffens the valve, and it has abnormal opening and abnormal closing, which can lead to narrowing of the valve and in some cases leaking and narrowing. This is a picture of a calcified aortic valve on a CAT scan. The reason I show this picture is you can see the valve in the middle there, and there's 3 symmetric leaflets, and the white parts are calcium deposits, which are like bone. So they show up on an X-ray just like a bone. And they're very much rock hard, just like a mineral. And so it makes it much harder for the heart to beat to open up those very stiff leaflets. This is another example of that calcification. So this is a picture as we're preparing to do a transcatheter valve replacement. And you can see in the back on this X-ray, you see the spinal column on the right side of the picture. Those stacked rings are spinal bones, vertebra. And then right next to where our wire is, where we're going to put in a catheter valve, you see a dark shadow that's opening and closing every time the heart beats. That's the aortic valve leaflets, and they're full of calcium. And so we can mark them just on an X-ray, which is not normal. Normal aortic valves do not have calcium deposits. The most common cause of aortic stenosis is degenerative. So you can see 2 pie charts here, one in age group less than 70 years old and one in an age group greater than 70 years old. So in the age group that's greater than 70, over half of aortic stenosis is caused by degenerative causes, which is wear and tear of the valve that causes mineral deposits. On the left, you can see that that's much more commonly related to bicuspid valves. So that's an abnormal formation of the valve that develops at birth. And it leads to early degeneration. So a similar process, but it's because the valve is formed abnormally itself. And then at the bottom, an interesting point of fact, 12.4% of patients who are over 75 years of age have some degree of aortic stenosis. This is just a picture of a bicuspid aortic valve. So instead of that symmetric, uniform 3-leaflet appearance we saw earlier, you can see there are 2 leaflets. Sometimes these are symmetric and the same size, and oftentimes there's 1 very enlarged leaflet and 2 smaller leaflets that make up the second small leaflet. These valves don't open and close normally from the beginning of life, and so that leads to the early degeneration from increased stress and shear forces. Once you develop severe aortic stenosis, which is a severe narrowing of the valve, there's some classic symptoms to look for. The most common by far is shortness of breath, which would occur with normal levels of activity. So say, for example, you're used to walking around the neighborhood at a brisk pace, and over time, over weeks to months, you notice that you can't walk as fast or walk as far without some shortness of breath that's uncharacteristic for you. That might be a subtle symptom of a valvular symptom of valvular heart disease or aortic stenosis. Other symptoms that can happen just less frequently are chest pain, chest discomfort, fatigue or lethargy, and then even in extreme cases, the abnormal flow and the abnormal blood pressure from severe aortic stenosis can cause passing out spells, and that's a really advanced sign and usually an indication that we need to act quickly. This is a curve that shows the average survival without treatment in patients with severe aortic stenosis. So this is once severe aortic stenosis has been diagnosed and the patient has symptoms. This is if nothing is done. And you can see over time the curve goes down fairly rapidly. It goes from 100% survival to, at 2 years' time, about half people can survive 2 years without any treatment alone. So it really is a very important diagnosis to make in order to help prolong life because we have some very good therapies to offer. The classic initial therapy for severe aortic stenosis was replacement of the heart valve through surgery, or surgical aortic valve replacement. There's really two types of valves that can be put in as a replacement for a severely stenosed valve. One is a bioprosthetic that's made up of fabric and plastic, maybe some metals, but then the primary parts are made up of bioprosthetic parts, like parts of a cow heart or lining of a pig heart. Those usually last 10 to 15 years, depending on the patient. On the other hand, there's a mechanical valve, which is made up of rigid plastic or metal. That lasts 20 plus years. It's much more durable than a biologic valve. But the main drawback of a mechanical valve is that it requires Coumadin. But both of these valves are put in the same way, which is a surgery, an open heart surgery. So you can see here a picture from an operation. The patient has had an incision in the chest and then an incision through the sternum, the main breastbone. The breastbone is then divided with a retractor and the chest is opened up. The heart is stopped. The patient's put on a heart-lung bypass machine, and then you can see in that original picture there, those are sutures that are getting prepared to put in a new aortic valve in this patient after having cut out the old aortic valve. The main drawback of a surgical aortic valve replacement is the recovery. The recovery from the incision, you'll be in the hospital for 5 to 7 days, and typically will take a month to 3 months to get back to to normal functioning after the surgical aortic valve replacement. It's an excellent treatment for for severe aortic stenosis, but there are new methods that we've developed over the past 10 years. So the question is there a better way to do it? Is there a way to get to the aortic valve without having to go straight in through the chest? These are some pictures from a man named Dr. Alain Cribier in 1990. He's a French cardiologist. And in the advent in the 1990s, what was new in cardiovascular disease was stents for coronary heart artery blockages, which you may have heard of people having, some family and friends may have had it, or even yourself. So these stents are put in through catheters, which is plastic tubes using wires. It doesn't require incisions in the chest, doesn't require incisions in the skin to get to an artery. So this is some mock-up sketches of how this might be done for a heart valve. You can see there on panel 1, the native aortic valve is depicted with a catheter put across it, and inside that catheter, a stent. Loaded inside that stent is biologic tissue that makes up a bioprosthetic aortic valve. It's made from parts of a cow heart, and then it's expanded into place using a balloon. Once it's put into place and stuck in place, it replaces your old heart valve, and then the balloon is removed from the body and the valve stays in place. The old heart valve is pushed out of the way, and the new heart valve unfurls like a sail and starts to work. The first transcatheter aortic valve replacement was performed by Dr. Alain Cribier in France in 2002. The patient was very ill and was not otherwise a candidate for a surgical aortic valve replacement, which was the standard of care at the time. And he was awake during the procedure, survived, and lived many years afterwards. This is an example of what it looks like to get a transcatheter aortic valve deployment in the body. You can see we have a wire and a catheter up from the leg artery, up and around the aorta, which is the main artery in the body. And then at this moment here, we start to inflate the balloon, and the stent, which the valve is loaded in, is inflated. Then that balloon is deflated. And at the end here, you can see we start to take that balloon out of the body. The balloons, the wires, and the catheters are taken out, and the valve stays in place. Here's a picture of the same aortic valve and aorta after we've deployed the TAVR valve. And so that stays in place for the rest of the patient's life. There's really two main valves that we use for transcatheter aortic valve replacement. One is the Edwards SAPIEN 3 valve. It's made out of bovine pericardium, or the lining of a cow heart. It's put on a cobalt chromium stent, which is stainless steel, and it has a fabric skirt at the bottom there. You can see the bottom of that valve has this skirt all the way around. That helps the valve seal so there's no leaking around the valve. And it's deployed with a balloon, as we've seen in these other pictures. The second valve that we often use is called the Medtronic Evolute valve. It's made out of porcine pericardium, or a pig heart. It consists of nitinol, which is a nickel titanium alloy, which was originally developed by the Navy for submarines. And it expands on its own. We don't use balloons to expand this valve. When this valve is cold, it's actually quite fascinating. The valve shrinks down into a very, very small shape, like a pencil. Then when it becomes warm inside the body, it expands in place. And we have a catheter-based system to control where it expands and when, so that it lands in the right spot. And it's actually recapturable, so we can put it in and out and make sure we get in just the right place. This is an example of a valve-in-valve TAVR. Dr. Allen is going to speak about this in a little bit, so I don't want to steal his thunder. But if you've had a surgical aortic valve replacement in the past, that doesn't mean you're not a candidate for getting a transcatheter valve or minimally invasive valve. Very often we're able to place those types of valves inside surgical valves to replace them that way. And this is an example here of this picture that I'm showing of one of the self-expanding valves. You can see the wide crown at the top there after we've put the valve in place. And then we're using a balloon here, which is expanding here, using that balloon to make this valve expand as big as it can so we can get optimal deployment and optimal pressure gradients. How do we get in? How do we put in a minimally invasive valve? Well, we don't go in through an incision in the chest or through the sternum. There's a number of different arteries we use. By far, the most likely is a transfemoral artery, which is an artery in the groin. 90% of the cases we do is from that artery. We can also go in through veins in the legs that cross over to the aorta. We can go in through the tip of the heart, called transapical. We've pioneered a technique here at St. Luke's where we're going through the carotid artery in the neck, and a surgeon makes an incision and opens up that artery, and we place the valve in through there. But all roads lead to Rome, as they say. And so any of these arteries will ultimately lead back to the heart and lead back to the aortic valve, and we can replace the valve through any of these initial routes. So what do we need before we do a TAVR? First is an echocardiogram. That's an ultrasound of the heart. That's going to diagnose the actual problem. Pulmonary function test to see how well the lungs are working. Carotid ultrasound to see if the arteries in the neck are affected, and if that could potentially put you at risk for stroke during a valve replacement. Everyone gets a heart catheterization, and probably the most important is a CAT scan of the chest, abdomen, and pelvis. And what we're looking for here is both the size and shape of the aortic valve, so we know what size valve to put in. And also we look at all the arteries in the legs and the arms and the neck to see where the best place to put in a valve, where the healthiest artery is, the biggest artery, so we know what's the best, safest route to go. There are some complications that can happen with this. It's not safer than open heart surgery. It's just a better recovery. 1 to 2% risk of stroke, 1% chance of dying, and then damage to an artery requiring a stent or surgery to fix. There's a chance of leaking around the valve. It's about 3%. And then there's always a chance of a permanent pacemaker. The reason a pacemaker might be necessary is the electrical system in the heart. You can see here a generic diagram of the electrical system, and the aortic valve sits right here. So when we place a valve in through balloons, ultimately that valve can press on the green electrical system there and damage that wiring and cause the need for a pacemaker to replace that function. Leaking around the valve. So this is an example of a valve that has a leak around it. And then you can see there on the left side, if there's a leaking around the valve and it is causing a problem, we can ultimately come back in later and put a plug in to fix that problem. If TAVR goes according to plan, you'll come to the hospital and check in on a TAVR day, which is usually Tuesday for Mid-America Heart, St. Luke's. Procedure takes about an hour. You go to the recovery room 4 hours later, usually walking around 3 to 4 hours after that, and a regular hospital bed a little after that. Most people go home the next day. So you spend one night with us, and the vast majority have healed up and recovered and ready to go home. Typically, there's a valve clinic appointment in a week and then a month to make sure everything looks like it's healing well. Not everyone who gets a transcatheter aortic valve replacement becomes a rock star, but some do. So you may have heard in the news, Nick Jagger was a very famous patient last year who underwent a transcatheter aortic valve replacement in New York. He was home the next day, and he was on the road doing shows within a few weeks. So it's possible to go on tour with the Rolling Stones after after getting your own TAVR. Thank you very much.
Thank you, John. Our next speaker is my colleague, Dr. Adnan Chacharwala. He's going to give us an update on catheter-based repairs for mitral and tricuspid valve disease.
Thanks, David. To start with, mitral regurgitation refers to leaking of blood backwards through the mitral valve on the left side of the heart. This can occur for different reasons, and on the left is represented degenerative mitral regurgitation. Sometimes we use the terms mitral valve prolapse or flail mitral leaflet. We also talk about ruptured cords. And all of these refer to a structural problem in which the mitral valve itself is not fully intact, and therefore there is some gap for blood to leak backwards. And in functional MR, also known as secondary MR, on the right, the problem is more with the heart itself. And if the heart enlarges and the valve gets stretched out, so to speak, and can't come together, then there can be a gap that lets blood flow backwards. And it's important to understand the mechanism of mitral regurgitation because the treatment options are different. MR leads to heart failure, and it's a vicious cycle, so to speak. So if you start at the top, you have mitral regurgitation leaking of blood backwards through the mitral valve. This increases the load on the heart. There's extra volume that the heart has to pump forward with every heartbeat as a result. And this can lead to myocardial injury or injury of the heart muscle itself, and then heart muscle dysfunction or left ventricular dysfunction. The heart can enlarge due to the extra volume of blood that is being pumped with every heartbeat. And then, as we talked about, the enlargement of the heart can further stretch out the valve and increase the mitral regurgitation. So all of this leads to congestive heart failure if unchecked. The medical management of mitral regurgitation results in poor outcomes. So in this study, over the course of 5 years, when patients have significant mitral regurgitation and they're managed only medically, 50% of patients are dead at 5 years, and 90% of patients have been hospitalized with heart failure. Surgery improves survival. In the left is a kind of an overall population, and on the right is a matched population. And in both groups, surgery improves survival compared to medical management, which is the dark black line. So the problem is that many patients don't get surgery. For example, in a Canadian study, only 57% of patients with severe mitral regurgitation were referred to a surgeon. In a European study, 49% of symptomatic patients with severe mitral regurgitation did not receive a surgical evaluation. And then a US study at the University of Michigan, approximately half of patients with severe mitral regurgitation underwent surgery, and of those who did not have surgery, 75% had at least one indication for surgery. So what are our options? Well, this doctor says, your medical problems are more complicated than I thought. I am going to refer you to another doctor who has more medical insurance than I have. But in reality, these are the motivations for catheter-based treatment of valve disease as an alternative to surgery. As we know, many patients are poor candidates for surgery due to advanced age or other medical problems. And if we do nothing, patients will have increasing symptoms and loss of function, irreversible heart damage, and the risk of sudden decompensation or death. So I want to start by talking about MitraClip, which is a method for transcatheter mitral valve repair. And in this cartoon, you can see that in panel A, what we do is that we come in from the vein in the groin up to the heart. And in panel C, we cross from the right to the left side of the heart. and we aim down to the mitral valve. The mitral clip looks like a little clothespin, and the idea is to clip the two leaflets of the mitral valve together where the leak is and reduce the leak, but still allow the blood flow, still allow the valve to open on both sides of the clip so that blood can flow in the right direction. And that's kind of shown in panels G and H. So these are actually images from a case that we've done. So this patient has severe mitral regurgitation. You can see the two leaflets of the mitral valve opening and closing on the left, but there's a gap. And the valve leaks severely in the middle of the valve. All this color that you see is blood leaking backwards through the mitral valve. So this is a view of our mitral clip. We're directly above the mitral valve. You can see the two leaflets opening and closing, and the clip is kind of in the open position with the arms at 180 degrees. And here we see in a 2D image that we've dropped the clip below the two leaflets now, and that the two leaflets of the mitral valve are actually kind of bouncing on the two arms of this mitral clip. And then on the right, when we close that clip, we grab the two leaflets and pin them together. And here we have an image similar to what we showed in the cartoon. The two leaflets of the mitral valve are pinned together in the middle. To the left and the right of that mitral clip, you can see that the leaflets open and close so that blood can flow in the right direction. And now when you look at color on the right, you can see that there's a significant reduction in the leaking through the middle of that mitral valve, only a mild leak, whereas the leak was severe to start with. So here's a direct before and after picture looking at the color flow and the large volume of blood leaking backwards before the procedure and the very small amount leaking backwards after. Now, the best part about many of our transcatheter procedures is the quicker and easier recovery. For mitral clip, for example, probably 90 or 95% of our patients go home the next day with a much quicker recovery than an open heart surgery, for example. The other, transcatheter therapies that are available are all meant to mimic surgical procedures. So one of the things that surgeons do when they perform open heart surgery on mitral regurgitation is that they can put a ring around the valve to kind of cinch it tighter, kind of like putting a kind of like wearing a belt to cinch up your jeans or your pants. And the idea is that that brings those leaflets, in closer together and reduces the gaps between the leaflets. And so surgeons, this is called surgical annuloplasty, and there are different shapes and sizes of rings that the surgeons can use. But we've adapted some of this into transcatheter therapies. So for example, this millipede device also comes in through the vein in the groin, goes up to the right side of the heart, and you cross from the right to the left. But the way this device looks is like a kind of like a frame that is screwed in all around the valve annulus and then can be tightened, much like a belt would be. So there's an ultrasound probe that's being used as part of the device, and that's how you see each one of these screws. You screw it into the right spot, and now we're bringing the device in to cinch the valve together. So that's the millipede procedure. And what's next are trials of transcatheter mitral valve replacement. So these trials are, roughly 12 years behind the transcatheter aortic valve replacement trials because the mitral valve is kind of more variable and complex in its anatomy. But there are three trials that are currently three devices that are currently in the trial stage, and many more to come, most likely. And we have a variety of approaches coming in transeptally, as I showed you with the mitral clip and the millipede procedure, or transapically, where the catheter comes directly into the apex of the heart in between the ribs and the left side of the chest, or a mini thoracotomy approach, which is kind of a hybrid surgical and catheter-based procedure. So in specific, we're involved in a trial using the Tendyne valve, and the Tendyne valve in panels A and B, you can see, has a large flared cuff which houses the valve inside of it. And then there's a tether or drawstring, so to speak, and an apical cap. And if you look at the bottom two images, these are CT scans demonstrating a tendyne prosthesis in place. And you can see that the valve sits in the annulus of the mitral valve, and then is tethered to the apex of the heart by the apical tether. The apical cap sits on the outside of the heart, and that's what not only tethers the valve, but helps to seal the hole that was made for the catheter. And the tendyne valve has been looked at in small studies. The first 100 patients treated demonstrated excellent technical success, so 96% technical success rate with a only 6% mortality rate in the first 30 days and 26% at 1 year. Among survivors at 1 year, almost 90% had either mild mitral regurgitation or no symptoms related to their mitral regurgitation. So very successful in the early experience, but now we're using this valve in a much larger nationwide study. And that's called the Summit trial. So what about tricuspid regurgitation? This is the same concept as mitral regurgitation, leaking of blood backwards through the tricuspid valve. This is on the right side of the heart. And we have similar devices like the TriClip, which looks like a MitraClip, but has some special device features to help clip the tricuspid valve. This was looked at in the Triluminate study, again, a small study of early feasibility. And again, this showed good success. 87% of patients had at least a 1-grade improvement in the leaking through their tricuspid valve. And if you look at the right side, patients at baseline had severe, massive, or torrential MR to begin with. And after the procedure, almost 60% of patients had either moderate or less tricuspid regurgitation. Patients improved in terms of their functional status as measured by NYHA functional class. So when you look at NYHA 1 or NYHA 2 functional class, that equates to a patient being able to walk 1 or 2 blocks without having shortness of breath. And at baseline, only 25% of patients were in that good of a condition. And after the procedure, 80% of patients could walk 1 or 2 blocks without being short of breath. So that's a good improvement. And then if you look at KCCQ score on the right, there was a 14% increase. A 5% increase in that score is felt to be clinically meaningful. So a 14% improvement is 14-point improvement is quite impressive. What's new is something called the Pascal device. So this is meant to function somewhat like a MitraClip, but it has some new device features. And we're involved in a trial where we're using this on the tricuspid valve. And that is called the CLASP-TR pivotal trial. So we're enrolling patients in that trial as well. There's a randomized group, and then there's a single-arm registry for patients who don't have perfect anatomy. So the key inclusion criteria for that study is that patients have severe symptomatic tricuspid regurgitation despite medical therapy, which often consists of diuretics or fluid pills. They've had heart failure symptoms or heart failure hospitalization within the last year. This is for patients who are at high surgical risk or intermediate surgical risk. The lower risk patients still may be better off having surgery. And then maybe the most important is that the anatomy has to be appropriate for this type of a procedure. So we're looking at the leaflets, we're looking at the cords, we're looking at calcium buildup, and assessing whether patients are candidates for catheter-based procedures as alternatives to surgery. So in terms of finding the right patient, that's perhaps the trickiest part. If you try to do the wrong procedure on the wrong patient, you're unlikely to be successful. And this is why we see patients in our multidisciplinary valve clinic with a cardiologist and a surgeon together. We try to get all the right imaging studies ahead of time so that we can review all options and pick the right treatment for the right patient. And sometimes the right treatment may be not to do anything at this time. So in conclusion, Transcatheter mitral valve repair with MitraClip has been approved for patients in the US since 2013, and so we've got great experience with this procedure. Transcatheter mitral valve annuloplasty or transcatheter ring procedures and transcatheter valve replacement trials are ongoing. And now we're testing transcatheter tricuspid valve solutions as well. It's important to understand that surgery may be the best solution for many patients and that a heart team approach is essential. Thank you.
Thank you, Adnan. Our next two speakers will focus on surgical options for valve disease. The first will be given by Dr. Jessica Hymas. Her topic is surgical options to address mitral valve disease.
Thank you, David. My name is Jessica Hymas. I am a cardiothoracic surgeon here at the St. Luke's Mid-America Heart Institute. Today, my topic is to discuss surgical treatment of the mitral valve. To start off, we'll give you some background of the heart. There are 4 valves in the heart. The first valve is the tricuspid valve, followed by the pulmonary valve. Blood then goes over to the lungs and comes back to the left atrium. It travels through the mitral valve into the left ventricle and then out to the aortic valve to the rest of the body. The valve that we're going to discuss more thoroughly today is actually the mitral valve. So when we talk about mitral valve, the mitral valve can have disease. But what is mitral valve disease? We usually classify mitral valve disease as either mitral regurgitation or mitral stenosis. Mitral regurgitation means that the valve is leaky. Essentially, a lot of times it happens because the valve doesn't close. There's a leakage of blood that goes backwards through there's a leakage of blood that goes backward through the mitral valve each time the left ventricle contracts. If you look at the picture down below, the first picture is an image of the mitral valve intact, and it's actually closing. You can see below the mitral valve, there is cords that attach it to the muscle of the heart. That is the normal mitral valve, and that's what it's supposed to look like. The second picture from the left shows that the mitral valve leaflets aren't actually closing. And you can see a little darker red spot. That's where there's a leakage of blood back into the left atrium from the left ventricle. And again, you can see that the problem there is that the leaflets are not coming together. The next picture over again demonstrates how those leaflets aren't coming together, as well as the fourth picture. Now, opposite of that is mitral stenosis. We talked about mitral regurgitation being a leaky valve, but mitral stenosis means the valve is restricted, meaning the valve doesn't really open. This can happen over time, but essentially it's a narrowing of the mitral valve opening, preventing blood going to the left ventricle. It restricts blood from the left atrium to the left ventricle. There are many causes of mitral valve disease. Some of these can be degenerative, meaning it happens over time. Some patients can have connective tissue disorders, such as Marfan syndrome, to name one. Endocarditis can happen. Endocarditis means an infection of the heart valve. When this happens, sometimes there can be cords that break. Sometimes the infection can actually tear a hole through the actual valve leaflet. Another cause is trauma or ischemia. Ischemia essentially means that the heart muscle itself is not getting enough blood flow. And what happens then is the muscles of the heart aren't working correctly, which can sometimes damage the mitral valve apparatus, meaning it can't close like it's supposed to. Some patients can actually have congenital problems of mitral valve disease. Other patients can actually have a disease not of the valve, but actually of the ventricle, meaning that the muscles get pulled apart because the ventricle dilates. This sometimes happens in cardiomyopathies. There are risk factors for mitral valve disease. One is unfortunately older age. As we get older, sometimes we can have changes in our heart intrinsically or in the mitral valve structure. The valve can actually calcify over time. History of certain infections can affect the heart, meaning that rheumatic valve disease can sometimes cause that valve to actually calcify or sometimes can cause it to become leaky. There's a history of heart disease or heart attack can sometimes be risk factors, as we talked before. If for some reason the heart muscle gets a lack of blood flow, sometimes that valve may or may not open like it's supposed to. Again, we talked about congenital heart disease. And another factor is those who've received radiation to the chest. Some people have no symptoms of mitral valve disease whatsoever. A lot of times this happens when the mitral valve disease is not to the point where it's severe. Some patients may just have a slight murmur or it's an abnormal heart sound. Most patients begin to develop shortness of breath or fatigue. In some patients, they also develop something called pulmonary edema. Pulmonary edema means that the water will back up into the lungs. So this sometimes happens when the valve can be extremely leaky. The first place that it can back up to, or the blood can back up to, is actually the lungs. And when this happens, sometimes people actually develop shortness of breath, and it's because of this volume overload in the lungs. Some people develop congestive heart failure, meaning that when patients have a long-standing mitral valve disease, sometimes they can actually develop a weakness of the heart muscle as a result, which can result in swelling of the legs and even irregular heart rhythms in some patients as well. Now, there are different treatments for mitral valve disease, which you'll learn today. Unfortunately, for some people, they're not candidates for all options of these mitral valve repairs or replacements. Surgery is the gold standard of treatment for mitral valve disease. And the goal of surgery is to restore the valve to a normal function by repair or replacement. Now, when we talk about mitral valves, we always try to repair it when it comes to surgery. The type of mitral valve repair depends on why the valve is not working correctly. For example, Dr. Skolnick has mentioned the ultrasound of the heart, or the echocardiogram, that can help us diagnose some of these valve lesions. Now, when we look at how these valve lesions are found, we can a lot of times plan accordingly and how to fix these valve lesions. For example, when I showed you the picture earlier of the cords attached to the underside of the valve, sometimes those cords can break. And when they break, what happens is a part of that valve leaflet doesn't come together like it's supposed to. And so sometimes what we do is we'll actually put cords on the valve as a type of repair. What those cords do is it attach it back to the heart muscle so that it'll again come together and will stop leaking. Sometimes a piece of that leaflet becomes a little bit extra, and so we cut out that extra part. As you see on the slides on the left, on that middle slide, we do what's called a triangular resection. That's where we cut out a piece of the leaflet, sew it back together, and then once we're done, we actually put a little band over the mitral valve leaflet that can actually help support the repair. Sometimes we have to cut a little bit more of that leaflet out. We call that a quadrangular resection. And again, we always want to support that valve repair with a band, which will help secure that valve leaflet and help it last a little bit longer. Now, unfortunately, we can't always repair a mitral valve, especially when a valve is extremely calcified. So when that happens, we sometimes have to replace that valve. And there are truly two types of valves that we use. One is a mechanical valve and one is a tissue valve. I'm going to first start with a mechanical valve. Mechanical valve is made of metal. This is what you'll see on the left, that black structure. Usually it has two leaflets that'll actually flap open and allow blood to come through. And when it's time to close, the valve leaflets will completely close off that opening. There are advantages of a mechanical valve. And one of those advantages is that the mechanical valve is extremely durable. When taken care of, this valve can last you the rest of your life. It has a really wide opening, so we can allow a lot of blood flow to get through, which is actually in a lot of patients' benefit. There are some disadvantages of a mechanical valve. One of those is that it does require a blood thinner called warfarin, or Coumadin is the other name for that. Unfortunately, right now in the United States, the only medication approved for a mechanical valve is Coumadin or warfarin. The other side effect or the disadvantage of a mechanical valve is that sometimes people can actually hear that valve clicking. Sometimes people can be really sensitive to that noise and they may not like it. Most patients after the first week or so, they become immune to hearing that noise. Now, the other type of valve that we have is a bioprosthetic valve, or we call it a tissue valve. Now, this valve can usually be made of either cow or pig pericardium. One common question that we get when we put these valves in are, do you have to take any immunosuppression from a bioprosthetic valve? And the answer is no. This tissue that we use for these valves is specially processed, so you will not need to take any immunosuppression. There's no cells that are still active on that tissue. But what this valve does is it's actually made to mimic our own tissue. And so because of that, because it's a soft, pliable valve, we do not have to take any blood thinners like Coumadin after this valve is implanted. The only thing we ask is an aspirin a day, which a lot of patients are already on. Again, the advantage of this is you don't have to take blood thinners like Coumadin. The other advantage of this valve is that in the event that it does wear out in 10 to 15 years, there are options for a potential transcatheter valve replacement in the future. And this will be something that you would talk with your surgeon and your cardiac team about. Now, the disadvantages of this valve. Again, it mimics our own tissue. It's one of those things that can last a long time, but it may not last you a lifetime, meaning that in the mitral valve position, this valve lasts maybe 10 to 12 years, sometimes less, depending on certain medical conditions that you may have. And so if this happens to wear out in 10 to 12 years, there is a chance that you might need an additional operation in the future. So it's one of those things, again, to discuss with your healthcare team. Now, how do we do this? Well, we have certain approaches as far as how we implant these valves. One is the conventional way, which I'm sure many people have heard about, called a sternotomy. That's where we go down the middle of the chest and divide the breastbone. However, we do have some other minimally invasive options, meaning that sometimes we only go through part of the sternum. We sometimes actually go to the chest and make what we call a mini thoracotomy. That's a fancy word for just a small incision on the left or right chest. We also sometimes do this using the Da Vinci robot. We sometimes use this with assist devices such as the robot. So to provide a little more clarity, the conventional approach is that sternotomy incision, which you'll see on the picture on the left. That's again where we go through the middle of the chest, divide the breastbone. Once we're all done with the surgery, we put that bone back together with stainless steel wires. And the big restriction after that is there's really no heavy lifting, nothing more than 10 pounds, no heavy pushing or pulling for 6 to 8 weeks. So again, that's one of the downsides. One of the benefits is that really patients tolerate this pretty well. Now, some of the other surgical approaches that we have, you'll see on the slide to the right. So we sometimes go through some small incisions on the chest, and we call those mini thoracotomies. Normally, depending on the mitral valve repair, we tend to go through a small incision on that right chest, and patients are put on the bypass machine through a small incision in the groin. Now, the surgical approach depends on truly the past medical history. For example, some patients, depending on radiation or other prior surgeries, may or may not be a candidate for certain approaches. So again, this is something to talk with your surgeon about. Now, the other thing that can sometimes impact the surgical approach will be the need for other procedures, such as bypass procedure or another valve. Another thing that we also take into consideration is patient preference. As far as your activities and what you do for a living may also impact the surgical approach. Now, one of the surgical approaches that we have is actually a newer type of valve, and actually St. Luke's Mid-America Heart Institute is one of the 80 sites across the United States, Canada, Europe, and Japan that's currently enrolling patients, and this is called the Tendyne valve. So it's part of a trial that we're doing right now. The Tendyne mitral valve is actually a bioprosthetic valve that's designed to treat both mitral valve regurgitation and stenosis. The benefit of this procedure is that it's done in collaboration with both cardiology and cardiothoracic surgery without using the bypass machine. So this can actually save a lot of patients a lot of time and hospitalization. So if you look at the picture on the bottom, you'll see an example of what that Tendyne mitral valve looks like. It has a little cup, which looks like it's attached to a little tail with a button at the bottom. And you'll see why that button is important. So first of all, how we put this valve in, we make a small little incision on the left side of the chest, right at the very tip of the heart. What we're able to do is through catheters and wires, we're able to access that mitral valve and put that mitral valve, tendyne valve, up into the mitral position. Once we're all done, you can see that little tether and the button at the bottom. That goes to the very tip of the heart and it's held in place that way. So again, this is one of the options that we now have here at the St. Luke's Mid-America Heart Institute. Now, as far as reoperations, I discussed the types of valves and why we do certain types of valves because we do try to avoid reoperations if at all possible. However, surgical reoperations for valve disease can be done. Each patient is evaluated on a case-by-case basis. The reason that is because each reoperation increases the complexity as well as morbidity and mortality for patients. This is something that you should talk to your surgeon and your healthcare team about.
Thanks, Jessica. Our last speaker is Dr. Keith Allen, who's going to give us an update on what we call valve-in-valve TAVR, avoiding repeat open heart surgery.
My name is Keith Allen, and I'm one of the cardiac and vascular surgeons here at St. Luke's, and I have a special interest in the catheter valve procedures, and I'm going to spend the next 15 or 20 minutes talking with you about some challenging cases and some things that that you all might find very interesting. So one of the issues that we have when we're doing catheter valve procedures is that in order to get a valve that should be the size of a quarter into you, we've got to roll that valve up to about the size of a cigarette. And we've got to find a highway to the heart. These are all of the different blood vessels that allow us to get these valves into patients that need them. The most common way that we do it is through the big artery or the big vein in the groin. But there are some patients, about 10% of the time, that can't have the catheter valve procedure through the groin, and we've got to find an alternate access or an alternate way to get it in you. Our most common way that we do it now is through one of the big arteries in the neck called the carotid artery. So when you feel the pulse in your neck, that's the carotid artery. And you can see here in this CAT scan, these two very big arteries that find their way down into the heart very easily. When we're doing a catheter valve procedure, we're obviously doing it in the operating room and you're completely asleep. And this is what an OR for a carotid, or delivering the valve through the carotid artery, looks like when it's all set up. I'm going to show you some videos here. For the squeamish, you might want to look away or close your eyes because they will be some real photographs, but this is kind of a schematic, an actual operating room photo of what your carotid artery, that's labeled CCA in the middle of that photograph, looks like, and it's through a little incision down low in the neck, and it's only about 1.5 inches long. This just shows you a video of what that artery looks like, and it looks like a big rubber hose. You can see the clamp on that vascular structure, and that's ultimately what we're going to put that rolled up valve through. This just shows you now going in with the catheter, which is what the valve is going to slide through in order to get into the patient. And once that's in, you can see now we're loading or docking the valve, and that's me pushing the valve into the patient. And this is what the valve looks like on your right just before we're going to expand it or open it up. And here you see now that valve that had been rolled up like a cigarette now is being expanded with a balloon, and it pushes the bad valve out of the way, and now this new valve unfurls and works like a sail. It's a very elegant way to get the valve in you. Now, we obviously have to repair the artery that we went through, but you can see there's the hole in the artery, and then we simply stitch it up, and in the end, you've got a repaired artery, and then we reestablish blood flow to the brain and wake you up. And typically about 60% of patients that get this go home the next day. So it's a very, very nice way to get one of these catheter valves in a very challenging patient. So another topic of interest to ours, and it's our whole team, is what happens if you had a prior open heart and a surgeon, could have been me or one of my colleagues, or you may have had it somewhere else around the country, they put an aortic valve in you. So you've had what's called an aortic valve replacement. You know, these are made out of either cow or pig parts. The public knows them as pig valves, and these valves typically won't last you the rest of your life unless you're very elderly. So when this valve does fail, what are going to be your options? And I love this slide because it's all about perspective. Everybody looks at things out of two different lenses. And there really are two options when a previously placed surgical valve fails. One is to have another open heart operation. We call that redo surgery or reoperation. And the other is to have what is done is called a valve-in-valve procedure. It's where once again, we've got a valve that is already there. It's a surgical valve the size of a quarter. And remember the video I just showed you, how we take that valve that's the quarter and roll it up to about the size of a cigarette. And now we're able to take that valve and put it inside your old valve and do it just like I showed you in the video before. And that's called a valve-in-valve TAVR, or transcatheter aortic valve replacement. This is what it looks like when you're having surgery. That's what a surgical valve looks like. And when you do the valve-in-valve, you can see the surgical valve is there at the bottom. It's the white cloth-covered valve. And then the kind of chicken wire mushroom shape, that's what the catheter valve looks like as it's been expanded inside that valve. So one of the issues that we have with valve-in-valve TAVR is trying to oftentimes get a valve inside of a valve. And the problem with that is analogous to Russian nesting dolls. What happens with Russian nesting dolls? Each time you put a new doll in, it has to be a little bit smaller. So eventually you run out of room to do valve-in-valve TAVR, and it may not always work well. So in the field of heart surgery, size really does matter. You want to try to get the biggest valve into a patient that you can, because those are going to provide the best function. Well, one of the things that we've developed here at St. Luke's is the concept of bioprosthetic valve fracturing. And essentially what this is it tricks or fools Mother Nature into thinking that you're going to get a bigger valve in. Think about the Russian nesting dolls. What breaking the valve allows you to do is to put a bigger valve in than what you normally would have. And it's very analogous to your keychain. You can put a lot of keys on your chain, and I'll oftentimes pull my own keychain out. So you can get a lot of keys on there by simply stretching that keychain. This is a picture of some bench work that we did showing you what the metal frame of the surgical valve looks like when you break it, just like your key ring breaks, and it allows you to put in a bigger valve. So if you listen closely here and watch the video, you'll see what it looks like when this valve
beginning
breaks.
inflation.
And there you saw that valve fracture, and you heard the click or the pop. Once again, this is on the bench in the OR, but it illustrates what this looks like when you do it inside of a patient. And then here's what it looks like in real life. So remember the pictures that I've showed you, that mushroom-shaped catheter valve is now been put inside the surgical valve. And if you look at the frame of that surgical valve, where the balloon looks like it's got a dog bone, watch what happens when you blow this balloon up. So there you saw that valve pop, and watch it again. You can see the waist of that balloon go away and the frame of that surgical valve pop out. And it allows us then to get a very nice size valve into somebody who may not have otherwise had good options. The bottom line for a patient is if you've had a prior surgical valve, you have options. It's always about weighing the potential risks versus the benefits of having another open heart operation, which for many patients is the right procedure to have, versus doing something new, the valve-in-valve TAVR that I've shown you here. And to finish, it's really never one or the other. Patients need to come in with open minds because the heart team at St. Luke's is going to pick the procedure that's going to be best suited for the problem the patient has.
Thank you, Keith, for that presentation. This now concludes the educational lecture series of our presentation. Next up is a virtual cath lab tour where we perform our catheter-based interventions for aortic and mitral valve disease. Throughout this conference, you are more than welcome to ask questions in the chat box, which you'll find in the right-hand side of the screen. At the end of this presentation, you will receive a survey. We sincerely welcome your thoughts and ideas. We will start planning soon our 4th annual presentation of Valve Awareness Day for February 2022. We are proud of the valve program that we have built over the years at St. Luke's Hospital. Part of our mission is to educate our patients and our community. So thank you again for joining us for this presentation and lecture series on our Valve Awareness Day.
Welcome to St. Luke's Mid-America Heart Institute, one of the nation's best heart hospitals. St. Luke's offers the most comprehensive cardiovascular care program with more specialized cardiologists, experience, and innovative treatments than any other hospital in the region. While heart surgery may be the best therapy for some patients with valve disease, many patients are candidates for a less invasive catheter-based procedure known as a transcatheter aortic valve replacement, or TAVR for short. St. Luke's staff was the first to perform TAVR in the Kansas City area in 2008. To date, over 1,300 St. Luke's patients have benefited from this life-changing procedure. During this process, a multidisciplinary cardiac team will participate in your care. This includes your interventional cardiologist, cardiothoracic surgeon, imaging cardiologist, advanced practice providers, registered nurses, anesthesiologists, and valve clinic coordinators. Every step along the way, you will receive specific instructions tailored to you. On the day of your procedure, you will check in at the admitting office on the 3rd floor of St. Luke's Mid-America Heart Institute. After check-in, you will be taken to a pre-operative area where your care team will prepare you for the procedure. While in preoperative care, an IV will be inserted to administer medication and fluids, and an arterial line will be inserted to monitor blood pressure. When it is time, you will be transported to the procedure area. Your cardiology and cardiothoracic surgery specialists will perform your TAVR procedure in the state-of-the-art hybrid lab at St. Luke's Mid-America Heart Institute. This specialized environment is both a cardiac catheterization laboratory and operating room. The lab features equipment your heart team will use to perform the procedure and monitor your condition. TAVR procedures typically take 1 to 2 hours to complete. The procedure is less invasive and the recovery is quicker compared to traditional open heart surgery. After the procedure, you will be escorted to a hospital room to await evaluation by your heart team. Typically, you will remain in bed for the first 4 hours. If you have a temporary pacemaker, you will remain on bed rest until it can be safely removed. Following your TAVR procedure and prior to discharge, you'll be encouraged to get out of bed, sit in a chair, and walk short distances. After discharge, your progress will be monitored during follow-up visits at 1 week, 1 month, and 1 year post-procedure. Thank you for choosing St. Luke's for your heart care. You have the full support of our expert cardiac team before, during, and after your stay at St. Luke's.